Boleh.
Okay. Okay, good morning everyone. Today I'll be presenting on myocardial infarction. Supervisor Dr. Fairuz lah. So, topik ini besar lah, so I wouldn't be covering everything. I'll be covering more on the clinical aspects as well as the acute ED management lah. Contents I'll be covering will be the definition, the types, and how do you diagnose, the pre and in-hospital management, as well as a bit on the complications. Boleh nampak slides I yang I forward punya definition semua?
Nampak.
Nampak ah? Okay. Okay. So definitions. Okay, so sebelum ini acute coronary syndrome kita classify as unstable angina, non-STEMI and STEMI. So we know that it's a clinical spectrum of a coronary artery disease lah. But sekarang the latest CPG of non-STEMI ACS, they are combined unstable angina and non-STEMI. So for now, clinically, ACS will be classified into either non-STEMI ACS or STEMI. They are tak separate between unstable angina, non-STEMI and STEMI. It's two classifications only lah. And same thing in unstable angina, myocardial injury is absent. So troponin would be normal lah, cardiac biomarkers would be normal. So for MI, it's a myocardial injury, so troponins will be raised lah, and it's due to ischemia. So pathologically, MI is defined as prolonged ischemia causing myocardial cell death. Okay, and clinically, it's divided into non-STEMI ACS or STEMI. So these are the types of MI. There are 5 types, but my presentation will be covering more on type 1 and type 2 lah. So type 1 will be a spontaneous MI. It's related to ischemia. Usually it's due to arteriosclerotic plaque rupture or fissuring or dissection. Like the primary pathology is due to the arteriosclerotic plaque rupture lah. For type 2 MI, it's due to imbalance between oxygen demand and supply. So such as hypertension lah, coronary embolism or coronary spasm, causing like the imbalance between oxygen demand and supply. So the third type of MI would be sudden unexpected cardiac death. Usually patient will come with symptoms of a typical MI chest pain, just that with the cardiac biomarkers we tak sempat hantar or send already, but it's not resulted yet lah, and patient passed away before the cardiac troponins resulted. Okay, then we classify as type 3 MI. For type 4 MI is due to there's 4A and 4B. 4A is due to PCI and 4B is due to stent thrombosis, and for type 5 is due to CABG. Okay, coronary artery bypass graft. So the significance of dividing to different types is basically more towards the pathology and the prognosis and treatment lah. So there's another terminology called myocardial injury. So this terminology basically MI is one type of myocardial injury, because for myocardial injury we can divide it into ischemic and non-ischemic type. So MI is considered under the ischemic type of myocardial injury. Okay, so there are also
sorry pecahan. Tapi maksudnya this list ni bukan nak suruh hafal, tapi maksudnya you need to be aware lah, there are different types of MI. Tapi for our setting, or at least for your level, the focus should be on type 1 dengan type 2 lah. Type 3, 4, 5 ni kadang-kadang lebih kepada classification for academic purposes lah, rather than ada significance in terms of practicality. And of course we don't do cardiac surgery lah kat ED, so there's patutnya tak ada lah type 5 MI kat ED. Okay, carry on.
Okay, so how do we get to a diagnosis of MI? So I wouldn't be going through much on how do you take history and do physical examination lah, because I think for that part we should have known already. So how do you diagnose MI is basically the one most important thing is a rise and or fall in troponins, okay, with at least one value above the 99 percentile and accompanied by at least one of the following. So basically, to diagnose, first criteria is rise and or fall in the troponin, and then the others, it could be either due to the typical clinical history consistent with chest pain more than 30 minutes, such as a central chest pain radiating to the left arm, the neck, with sweating, nausea, vomiting, and all the other typical symptoms, or even non-typical symptoms such as just sweating or palpitations. Okay, for the elderly or the woman or people with comorbids lah. Okay, and second criteria would be ECG changes of ischemia or infarction, and or the development of pathological Q waves. I will show you all some ECG strips later lah. So the third one would be through echo or other imaging evidence of new loss of viable myocardium or new RWMA. And the fourth would be if there's a intracoronary thrombus identified through angiography or autopsy. So basically to diagnose
So takut salah faham dia rise and fall of troponin tu betul. It's one of the criteria. This is just a spin of the old criteria lah. And the old criteria used to be it has to be 2 out of 3 kan. History, ECG changes dengan cardiac enzyme. Now they're more specific to troponin. So it's troponin plus history or clinical sign lah. And the other yang dia mention dalam specific thrombus apa semua. So it's not just troponin. It's troponin and something else. So you have to have other features to say that it's MI. Jangan tengok buka komputer tengok troponin high MI. No, you have to still tengok patient lah. This is not an excuse to just do macam trace result MI. You still have to see patient and see. Okay, carry on.
Okay. So, more specifically, STEMI itself is diagnosed when there is, through the ECG strip, we see there's a ST elevation of more than 1 mm in 2 contiguous leads. More than 1 mm means one small box lah, or a new onset LBBB in the resting ECG, as well as what we mentioned just now, through clinical, patient has ischemic type chest pain, and accompanied by a rise and fall in cardiac biomarkers. So this is more specific to STEMI lah. Okay, so this is what I've mentioned just now lah. How do you come to a diagnosis? Through the history, okay, where you get your provisional diagnosis and you do ECG. If there is a ST elevation and troponins are raised, then it's STEMI. If there's no ST elevation but the cardiac troponins are raised, then it's non-STEMI. Otherwise, it will be unstable angina lah. Okay, so this is a bit more specific into the ECG findings as well as the location and leads lah. So as mentioned just now, the definition for your how do you diagnose through the ECG would be more than 1 mm in 2 contiguous leads. But we can see, except for lead V2 and V3, there's more specific definition lah. So for leads V2 and V3, we can see that there is, according to the age group, there'll be different numbers lah. And for easy, like how for me lah, how I remember easier is usually I would just take 2 mm lah, 2 small box for leads V2 to V3. So other leads will be if there's more than 1 small box in 2 leads. For this V2 and V3, it will be if there's 2 small box in more than 2 leads. In more than 2 leads. Okay, as well as pathological Q wave. So yeah, you all just can take a look lah at the different leads. V1 to V3 will be at the anteroseptal. V1 to V6 it will be more extensively anteriorly, and V7 V8 will be posterior lead lah. V1 V2 is when we look at the reflection of V7 V8 posteriorly, where there will be ST depression lah, because it's a mirror of the anterior leads. So anterior lateral is 1 AVL V5 to V6, and inferior will be 2 3 AVF, and right ventricular usually we'll put the leads over the right side and we'll read on the ECG strip through the V4 lead lah. Okay, so next would be same thing, just that more on the which occluded artery lah, which artery is affected. So if it's a septal area, it will be at the proximal LAD. If it's at the anterior, it will be at the LAD lah, left anterior descending artery. Okay, so if V5, V6, it will be the distal LAD. So for the inferior and the posterior lateral, which basically the inferior, posterior, and the right-sided infarct would be more towards the right coronary artery lah, and laterally it will be the circumflex. So these are a few ECG strips just to show you all how you diagnose. So first on STEMI, we see the first one, according to definition just now, where there would be more than 1 mm in 2 contiguous leads, except for V2, V3, where there's more than 2 mm in 2 contiguous leads, as well as pathological Q wave. So you all can see the arrow there and the red line where it shows that it's more than 2 mm, okay, above the J point, as well as there's pathological Q wave. Pathological Q wave means if the Q wave is more than 1 small square deep as well. So here it's way more than 1 small square lah. So the above ECG strip, you can see that there's changes over the V2, V3 lead, which is an acute anterior wall MI lah. So the ECG strip below, we can see that there's changes. There's ST elevation over the lead 2-3 AVF. So it's an inferior MI. Okay. So for the next one, non-STEMI. Basically, non-STEMI is when there's also prolonged ischemia, but not to the extent of a very severe infarct lah. So in the ECG strip, you can see basically ST depression as well as T wave inversion. Okay, so for the above strip, you can see that there's T wave inversion lah over the arrows, lead 3, lead 2, okay, V5 and V6 lah. Okay, and for the below ECG strip, we can see that there's a ST depression over the arrows, V3 to V6. So this is pointing towards non-STEMI lah. So there are cases where we see ST elevation features, but it's not STEMI. So basically, the above strip, you can see that there's ST elevation in almost all of the leads, and the shape is more towards a concave shape. This points towards more towards pericarditis lah, of course, according to a history and physical examination as well. And the below strip, you can see that there is T wave inversion as well as a slight ST depression lah. So this is not necessarily also a non-STEMI. We have to correlate with the history, and based on the ECG strip, it's more towards like a reverse tick sign lah. This is due to digoxin toxicity. So there are also times when ST elevation and depression is not pointing towards MI lah. Okay, so this is on the cardiac biomarkers. So we can see there are many different types lah, but we usually would use troponin lah.
Is it okay if I stop you there, Jad?
Yeah,
okay.
can.
Is it okay if I stop you? Okay, sebelum kita pasal cardiac biomarker. With regards to the ECG, it's impossible lah for N to go through ECG pasal ST elevation, ST depression ECG in this setting. It's impossible lah. That's a whole another one day punya course. Tapi the point that they should get from the ECG changes ni, and it's never single lead. ST elevation ni or ST elevation, ST depression also, it never occurs in a single lead. It's always in macam a group of lead kan, inferior 2-3 AVF, anterior V2, V3, V4, lateral V4, V5, V6, high lateral 1 AVF. 1, 2, it's never just ST elevation. You also need to talk about reciprocal kan. Dia ST elevation will occur dekat a group of leads, and you will have reciprocal in different leads. So bila tengok di situ, not just tengok ST elevation, tapi you have also to look at reciprocals. And hopefully you understand what reciprocals mean lah kan. And also terms yang penting, reciprocals, contiguous leads, you know kan, orang selalu cakap kan, MI in two, in one, in two contiguous, 2 or more contiguous lead kan, for the ST elevation to be significant. So maksud contiguous tu pun you have to understand lah the meaning of contiguous. Contiguous and reciprocal is very important, at least at the very basic in terms of interpreting ECG with ST elevation. Okay, carry on.
Okay. So yeah, if you all want to read more, I will share the link at my reference lah. Basically, the CPGs lah. Okay. So next, I will talk more on the cardiac biomarkers lah. So there are many types of cardiac biomarkers, but we usually use troponin lah because it's the most sensitive and specific cardiac biomarker. Okay. So in the latest CPG also, they mentioned on how we should use high sensitivity troponin, which we are using in our hospital lah, HS troponin. So they mentioned on they included a few risk scores lah, which I also won't be covering, but basically just for you for your information, like there's something called heart score where they actually use to rule out ACS, whether patient can directly discharge from ED or require admission lah. So they will use a risk score as well, coupled with your troponin as well as the clinical history to judge whether patient is fit to discharge or require admission. So basically, we can see through this graph also where the difference between troponin and high sensitive troponin, which is more sensitive, because after 2 hours you already can collect the sample through the graph here. So if the troponin is raised directly, we need to admit patient. Okay, if the troponin is not raised but it is taken after because the troponin will be raised within 3 to 6 hours. Okay, especially for high sensitivity one, it will raise after 2 hours. If it's taken at that time frame, then we can, based on that, do the risk score coupled with the clinical history. If the heart score is less than 3 and patient is pain free, then we can discharge from ED lah, and for early outpatient cardiology consult. Okay, but if we take the cardiac troponin out of the time frame within 2 to 6 hours, then we need to repeat one more. That's why usually it's important to ask the clinical history of the onset of symptoms lah, to know like whether the troponin we are taking is at the correct timing or not. Okay, if it's not at the correct timing, then we have to repeat a second sample. If it's for high sensitivity one, repeat 2 hours later. If it's more than the desired level, then patients still require admission. If it's still less than, with true criteria lah, the value less than the not raised. Basically, if it's not raised and there's a less than 50% change within the first and second sample, and patients still having pain with a high risk score, then also require admission. But if it's not raised and patient is okay clinically with a risk score less than 3, then patient can still be discharged lah. Okay, so
let me stop you there, Anne. Okay, sorry about this graph ni, supaya everybody is clear. This algorithm, kan kita banyak patient datang chest pain kan, you got so many patient datang chest pain kan, and everybody is to rule out ACS. This is satu algorithm yang people develop lah untuk acute chest pain service dekat emergency department. How you gonna sort out patient yang chest pain or chest pain MI. It's not a perfect system, tapi this whole system is based on high sensitivity troponin lah. So apa yang saya cerita pasal heart score apa semua ni mungkin something yang you're not familiar with. Tapi kan dalam managing patient MI, pernah dengar TIMI score kan? Everybody heard of TIMI score kan? Just show angkat tangan ke apa. TIMI score.
Yes.
Heart score ni is just another form of macam that lah. It's just a score for you to decide whether this patient ni high risk nak develop MI ke or low risk. So those yang low risk, you can hantar pergi MOPD, OKK bagi appointment. Those yang high risk, then you need to admit lah for specific therapy. So the details of heart score ni you kena baca lah, because if it's another lecture on its own. Tapi heart score ni basically dia assign point to certain punya values. Then if the point is high enough, then patient is high risk of developing MI lah. If the point is patient is low risk of developing MI. Tapi you have to remember, all this score, dia punya sensitivity or specificity dalam 98%, you still gonna miss 2%. So it's not perfect. Tapi this is the system that we have lah, because a lot of patient yang datang dengan chest pain ni very non-specific kan. History biasanya not classical, and the only objective thing that you can use is cardiac troponin lah, the cardiac enzyme. Tapi this is not our setting. This is the ideal setting dalam guideline lah. If we can create this acute chest pain punya unit dekat ED, it basically aim to reduce admission to the ward lah. So this is not common practice lah. You can take the principles of it, tapi you also can read around heart score. So if you want to be really good, and macam for every chest pain patient that you see, try lah kira heart score. Then it will help you to decide whether this patient is high risk or low risk to develop MI, and whether they are suitable to be discharged or not. It creates a bit a more systematic way lah to assess patient with chest pain. Okay, Kena.
Okay.
Boleh carry on lah.
Okay.
I just interject lah.
Okay, so next will be on the pre-hospital management lah. So it is important because ACS has a high morbidity and mortality among patients lah. So it's important that the pre-hospital management is very important to actually save more patients lah. So the public should actually be educated
Okay, for pre-hospital management, tak perlu fokus sangat lah, because in the end you guys work in the hospital kan. So pre-hospital ni nanti it is a different hole of different punya rabbit hole lah. So okay lah, pre-hospital management is important because you want to transfer patient from out the hospital to hospital quickly. Cukup. Then move on to other slide.
Okay. Okay, so yeah, basically what the general public should patients do lah. This one you all can read, and
this is all patient education lah.
Okay.
Okay. So tak apa, pre-hospital care tak perlu worry sangat. Chat ni pun tak payah risau sangat.
Okay.
It's good to know, tapi untuk for your ni, tapi this is important lah. Because now you're in the hospital kan.
Okay. So
hospital.
So we will proceed to the in-hospital management lah. So the main objectives pointing more towards STEMI lah, is actually first for pain relief, second to establish early reperfusion, and third is the treatment of complications lah. So this is more towards STEMI lah. For non-STEMI ACS is actually also pain relief, treatment of complications, and also for non-STEMI is more to depending on the risk of patient. Okay, I will show a graph later on when do we need to decide on revascularization and when we can just use medical therapy for patients lah. That is for non-STEMI ACS, but here is more on STEMI lah. So this is a chart on management of patients presenting with STEMI. So what do you do first when patient is in here? So of course through the history lah, we know that patient a typical history of MI, and then we'll do ECG, we'll take the cardiac biomarkers and confirm there's a STEMI. So what to do first is, if you really forgot everything, these 4 things is most important lah. First is start on DAPT, dual antiplatelet therapy. Okay, and then second is to give analgesia, which is usually a morphine lah. We give around 2 to 5 mg in every 15 minutes lah. Okay, and then third is your sublingual GTN lah to relieve pain lah for patient, and fourth is oxygen if SpO2 is less than 95%. Okay, so this is the 4, and of course continuous ECG monitoring lah. So this is the 4 most important things that you need to give patient lah when patient is diagnosed with STEMI. And then concomitantly, we also want to assess whether which reperfusion therapy is patient suitable for. So reperfusion therapy is basically to open an occluded artery lah. We want to achieve that as soon as possible. So depending on your onset of symptoms, if it's less than 3 hours, patient can either opt for primary PCI, percutaneous coronary intervention, or fibrinolytic therapy. But primary PCI is still preferred in some cases if it's a high-risk patient or if there's a contraindication to fibrinolytic therapy lah. I will show you all later. Okay, and if it's between 3 to 12 hours onset of symptoms, primary PCI is preferred. If it's more than 12 hours, usually we'll opt more for medical therapy or antithrombotics lah. So there's a second option. Okay, so if it's 3 to 12 hours and primary PCI cannot be done, then we can opt for fibrinolytics. Okay, let's say if the transport time is
sebelum kita proceed kan, so when you say medical therapy ni, what do you mean by medical therapy?
Basically
so,
giving
kan dalam more than 12 hours tu medical therapy, what do you mean by medical therapy?
Basically giving sub-Q fonda Paranox, okay, and then giving basically ACE inhibitors, beta blockers, statins.
Okay. So I just want to make sure that everybody is clear lah. Okay, fibrinolytics ni is your streptokinase, metallase dan sebagainya lah. You know, fibrinolytic kan. Medical therapy ni is your usual medical therapy lah. Beta blocker, ACE inhibitor, statins and whatnot. And antithrombotics here refer to aspirin, Plavix, apa semua. Okay, so there's a difference lah between antithrombotics dengan fibrinolytic or thrombolytic punya agent. So jangan confuse lah antithrombotic dengan fibrinolytic or thrombolytic punya agent. Just nak make sure benda tu clear lah. Kadang you never know kan. So that's why this is important for you dalam history to establish the time frame when patient develop symptoms. Sebab management will differ based on less than 3 hours, 2 to 12 hours, more than 12 hours dan sebagainya. Okay, so dalam ni juga you tengok kan, it's always primary PCI lah, it's the best choice. Tapi of course you need to decide on the best treatment based on practicality lah. Macam kita, we don't have our own cardiac lab kan kat sini. So it's a bit impossible lah to get semua patient with MI primary PCI. Tapi even if we do have cardiac lab kat sini with interventional cardiologist, you need to also think about whether the cardiologist tu 24/7 available ke nak buat primary PCI. Kan, you know, if patient datang at 3 o'clock in the morning datang dengan MI, you think the cardiologist, katalah ada satu cardiologist dekat HSAH, so you think he's going to be here at 3 o'clock in the morning nak buat PCI. So benda ni has to take into account. This is ideal, tapi unfortunately we live in a world which is not ideal, especially zaman-zaman COVID ni kan. So there is a lot of things, there are a lot of things yang akan delay or interfere with our ni lah, that needs to be taken into account. Ideally nak macam ni lah, tapi it's unfortunate lah. Okay, so okay, carry on.
Okay, yeah, so basically primary PCI is the first choice that we want to make lah. So there's also second option lah, if patient is within 3 to 12 hours onset, where we can go for fibrinolytics, and if it's more than 12 hours, where we can still go for primary PCI if patient is still having the ongoing ischemic chest pain and hemodynamically unstable lah. So together with your concomitant therapy, which is also your medical therapy and antithrombotics lah, DAPT, statins, beta blockers, ACE inhibitor, or your spironolactone lah. Okay, so this is for non-STEMI ACS patient. So this is for low risk patient lah. We can see the criteria below here. What is low risk? Basically no angina in the past, no ongoing angina, and so on and so forth lah. So for low risk patient, we will do the ECG and we'll do a stress test lah. If it's if patient has a normal ECG and a good negative exercise stress test, then we can just opt for risk factor reduction and medical therapy lah. If a patient having abnormal ECG and has a positive stress test, then we would probably want to opt for revascularization lah, invasive coronary angiogram. So this is for low risk patient. If patient which is intermediate or high risk, all of them should be considered for coronary angiography and revascularization. Okay, so
this is mainly for patients yang outpatient lah. So for us, kita tak bisa sangat lah. Mainly outpatient lah. This is what going to happen to patient yang you refer to MOPD dan sebagainya. Okay, carry on.
Okay,
boleh teruskan.
Okay, so this is what I just mentioned just now for the STEMI chart, where initially when we diagnose patient with STEMI, the 4 things we need to do lah. And first, if you realize that getting a first we of course we need to know how to recognize lah. So if we see that there's a very patient with suspected STEMI but you're unsure, okay, so we can try repeating the ECG at 15 minutes intervals, and then we can use additional chest leads as well lah, such as the V7 to V9, okay, the right precordial leads to detect posterior or right ventricular infarct lah. Okay, and then the 4 things I mentioned just now, where we give painkiller, morphine, okay, coupled with antiemetic lah, because morphine, the side effects of morphine lah, and then of course we want to set preferably 2 IV lines and to take your bloods lah, and also sublingual GTN as mentioned just now, DAPT, the dosage should be 300 aspirin and 300 clopidogrel lah. And if we opt to send patient for primary PCI, a higher dose of clopidogrel can be considered 300 to 600, or other choices such as ticagrelor. Okay, and also to give your oxygen if SpO2 is less than 95%.
Ticagrelor ni is something yang fairly recent lah. It's dia macam clopidogrel tapi dia skip the few. Sorry, tiba-tiba ada call masuk tadi. So ticagrelor macam clopidogrel, dia ada clopidogrel you need to be metabolized in the stomach before dia akan dapat active compound dia lah. Macam ticagrelor ni dia skip few of the metabolism steps, so dia function lagi cepat lah. So it's the preferred agent kalau patient nak going for primary PCI. I'm not sure whether we have it here or not lah. Obviously it's newer, it's more expensive. But the point yang I nak highlight ni, actually slide yang sebelum ni, yang pain management tu. Hello cuba pergi slide yang okay, pain. This is something that you guys selalu lupa. Patient dengan MI datang dengan pain. Pain needs to be managed because the issue with if patient is still in pain, dia akan be tachycardic, profusely tachycardic, and dia akan more stress lah. So you may end up causing the chest pain, the MI to get worsen. So you need to control the patient. That's why part of the medical therapy ni dia kadang bagi beta blocker to reduce the heart rate, to reduce the demand on the heart. You know the heart already dah kena attack kan, dah ada injury, and you want the heart to relax as much as possible. So it's very important for you to control the pain. Satu, because untuk supaya heart rate tak tachycardic, and you reduce the burden on the heart lah. So you don't worsen the MI. So and don't be afraid. Bagi je morphine and titrate. The main thing is titrating the morphine dose lah. Okay, carry on.
Okay. Okay, so yeah, so basically it's just a repetition lah, the 4 things we give, okay, and at the same time assessing which reperfusion therapy is suitable for the patient lah, based on their onset of symptoms. So yeah, so now I'll move on to reperfusion therapy. As mentioned just now, there are 2 types, fibrinolytic as well as PCI. So fibrinolytic usually there's a golden hour lah. If given within 2 hours from the time of onset of symptoms, it is most beneficial, and we only give to patients with STEMI. For PCI, as mentioned in the flow chart just now, less than 12 hours, if it can be performed in a timely manner by experienced operator, it is a preferred reperfusion strategy lah. Okay, so for fibrinolytic therapy, as mentioned by Dr. Fairuz just now, we usually there's a non-fibrin specific one and there's a fibrin specific agent. So streptokinase is a non-fibrin specific one, and tenecteplase is a fibrin specific agent. So the difference would be the difference between streptokinase and tenecteplase would be streptokinase it actually has a lower patency rate, which means it is actually less effective in treating an occluded vessel, in reopening an occluded vessel, but it also has a lower risk of bleeding, of intracranial hemorrhage. On the other hand, for tenecteplase, it is actually better in terms of reopening an occluded vessel, just that it has also a higher risk of intracranial hemorrhage lah. So over here we usually give streptokinase. So the regimen would be 1.5 mega unit in 100 ml of tamsuline or 5% dextrose over 1 hour. Okay, so for tenecteplase, we can see how do we administer in terms of patient's body weight, okay, over the chart down here. And because of a higher risk of bleeding, in patients of more than 75 years old, we should reduce the dose by 50% lah. And following administration of a fibrin-specific agent, anticoagulant is recommended lah. So either heparin, enoxaparin lah. And if we realize that we usually give okay, yeah, so we usually after 48 hours lah, we'll give this after giving the tenecteplase, we give patient heparin or enoxaparin and should be continued for at least 48 hours lah. Otherwise, we can also opt for sub-Q fondaparinux 2.5 mg daily. Okay. So what is a failed fibrinolysis? So a failed fibrinolysis is when a patient, after we give the streptokinase or tenecteplase, patients still have persistent chest pain, and then ECG still shows persistent ST elevation, and patient probably has hemodynamically is still unstable. Okay, so it is dangerous because a failed fibrinolysis can develop more complications such as heart failure and arrhythmia. So what we do is we would send patient for rescue PCI. Okay, they should not be given a second dose of fibrinolytic agent because there's no according to research, there's no difference lah of the survival. Okay, so yeah, as mentioned just now, the contraindications of fibrinolytic therapy, there's an absolute and relative contraindication. It's usually if you can't remember anything, just remember if patient has risk of bleeding, any risk of bleeding, then we should alert us whether to proceed with this fibrinolytic therapy lah.
Okay, this is something that you should ask dalam history relative contraindication, absolute contraindication. In any patient yang datang dengan MI or suspect MI, terus tanya siap-siap. Okay, carry on.
Okay.
Ni extensive list lah, boleh baca sendiri lah. I don't think and need to go through in detail each lah. Okay, carry on kan. Sebab dah 40 minit ni.
Okay.
Haziq nak present lagi.
Okay, Haris. Okay.
Banyak slide lagi ke?
Ada sikit lagi. The last
sikit
few.
lagi, okay.
This one high risk patient is the one I mentioned just now for patient less than 3 hours, where we choose primary PCI over fibrinolytic therapy if patient is a high risk patient lah. This is just the list of the high risk patients. Okay, And then
This is also quite ideal lah. In our setting, regardless patient ada benda-benda ni pun still, fibrinolytic lah.
okay, so for PCI, as mentioned just now, so when patient is standby, we actually give the 4 things, and if you anticipate patient for PCI, we can start with antiplatelet therapy lah. Your aspirin 300 and your clopidogrel or ticagrelor or prasugrel lah. Okay, as well as you can also start with antithrombotic therapy lah, which is your heparin, enoxaparin lah. Okay, so this is the last slide, complications of STEMI. So basically there are...
Okay, excellent.
Okay, there are a few complications.
Complication eventually mati lah. The worst complication is death lah basically. So they can develop anything lah. So cuma what the complication that I need you guys to be aware of, especially in patient yang you bagi Streptokinase or Metalase, the complication is called reperfusion arrhythmia. You know your MI, patient ada MI, straightforward kan, you start Streptokinase or Metalase kan. So what happen is the period masa you start thrombolysis tu, you need to monitor patient. When I mean monitor, patient needs to be on cardiac monitor yang ada defibrillator. You cannot just monitor on manual punya ni, and you cannot leave patient because patient bila tengah reperfuse tu on fibrinolytic, they at high risk of developing reperfusion arrhythmia. This reperfusion arrhythmia ni is usually VF or VT, and the immediate treatment is patient requires shock immediately. And if you manage to deliver shock immediately, patient ni akan macam dalam movie lah, patient akan terus sedar and doesn't require intubation apa semua. Don't bother with CPR, patient needs shock. So that's why you need to monitor patient on thrombolytic therapy. You cannot tinggal pergi huha-huha, main phone apa semua, and you need to pasang cardiac monitor yang ada defibrillator. If you don't take anything else from this lecture, itu yang antara point yang paling penting sekali lah. Okay? Okay? Clear kan? Clear?
Perfusion arrhythmia. Okay.
Reperfusion arrhythmia. All this complication ni okay? Okay, habis dah kan? Last slide kan?
Last slide.
Anyone got any question? Boleh je on microphone and tanya soalan lah. Kalau tak ada, kita move to Haziq lah. Dia ada dah lama 40 minit.
Okay.